Good morning, afternoon, evening to everyone, and thank you so much for joining this webinar. We are really excited to share with you some amazing findings from a really innovative piece of work that USAID's really thrilled to have been a part of. I'm Lisa Schechtman, and I am the Senior Policy and Partnerships Advisor in USAID's Center for Water Security, Sanitation, and Hygiene, and I will be moderating today. I just wanted to start off with a couple of housekeeping items for those who are not familiar with Blue Jeans. The first thing is that we are recording, and there should be closed captioning as well for those who need it. If you don't see that, please feel free to let us know, and we will make sure to turn that on if it isn't already. We will have the participants chat active. I see many of you already dropping messages in. And I'd like to just flag as well that we'll be using the Q&A box, which you should see over on the right-hand side of your screen. You can feel free to drop questions into that Q&A box as we go along this morning and afternoon, depending on your time zone. And we'll try to catch the questions if you put them in the general chat, but we'll be prioritizing the ones that come through that Q&A box. So please, as I said, feel free to drop them in. We will take as much time as we can to answer questions, but we'll also be providing responses in writing through that Q&A box as we can. If you look at the bottom of your screen, sort of under the slide and my face, you'll see a slider that lets you adjust what you're seeing. You can use that to increase or decrease the size of the slides if you need to take a closer look or to change the overall view. And then for any technical issues you might have, you can use the moderator chat to reach out to either KD or to Joelle, and they'll provide you with some support. I'm seeing a couple of chats that folks aren't able to hear, so I'm hopeful that you're able to figure that out. But if not, do feel free to send KD and Joelle a moderator chat, and they will be as helpful as they can. So I'm just going to say a couple of opening words before we go directly into our program. The first is it's really exciting to see such a large and diverse group of folks from all over the world joining this morning. It really reflects the holistic and kind of intersectoral nature of menstruation and all the work that needs to be done to make sure that people who menstruate are able to fully engage in their lives and have all of the options that they deserve. It's a really exciting activity that we're here to discuss today. So I just want to kick off by thanking the Gender and Development Hub, the WASH team in USAID's Global Health Bureau, Tetra Tech, Iris Group, and Athena Informatics, and Emory University. This was a really amazing collaboration that really reflects a whole of USAID commitment to addressing this issue. And you'll hear from folks representing all of those sort of communities in a few minutes. We have a lot of really interesting data to share today, along with the initial recommendation. If you could put up the agenda slide just so that we're going to start with remarks Jamila Biggio, who's USAID's Senior Coordinator for Gender Equality and Women's Empowerment. Then colleagues from the IRIS Group will present an overview of the activity and the results, and we will hear from the Acting Mission Director of USAID Nepal, as well as a WASH specialist in USAID Kenya, with reflections about how the activity on menstruation in the workplaces links to their mission priorities. We will also be pausing for Q&A after the first set of presentations. And then we'll go into the last two presentations on the cost benefit analysis and work to identify metrics that we could all be using globally to do a better job of measuring the experiences of menstruators who work. And we will finally have about 20 minutes for further Q&A for those who want a little bit more discussion and who have the time to stay on. So with that, I'm going to stop talking and turn it over to Jamila to kick us off.
Wonderful. Thank you so much, Lisa. And thank you, everyone, for joining us today. I'm so pleased to have the opportunity to be with you, to thank our implementing partners, our private sector hosts in Nepal and Kenya, and everyone who provided guidance and advice to make this innovative activity such a success. It is truly exciting to be together to think about a new area of work, to look at how menstrual health and hygiene, or MHH, how it is a critical component of gender equality for all menstruators, regardless of their gender identities. We know that menstruation can create complicated dynamics and challenges for people, and that it's incumbent on all of us to help provide holistic responses. We know that menstruation is a life course, that it is a regular occurrence for as much as 50 years of people's lives, during which people's context, knowledge, and resources may change. We know that it's an education issue, a health issue, a WASH issue. We know that whether menstruation is a positive or negative experience can impact people's basic identity, their agency, their self-confidence, and their mental health. And just as we know that menstruation can have a significant impact on girls' education, we're very interested in better understanding the impact that it can have on women's economic empowerment. And that's the gap that brings us here today, because we've recognized that most research on menstruation has focused on school-based settings or has looked at products, WASH, or other menstruation information. But as we've collectively focused more and more on women's economic empowerment, there's been a gap in our understanding between the links between menstruation and women's economic participation. And that gap has limited the kinds of policies and impactful investments that we can make. That's why in 2019, USAID's Gender Equality and Women's Empowerment Hub made the agency's largest single investment in MHH with the launch of the Menstruation in the Workplace activity that we're here to discuss today. As far as we know, this is the first ever significant investment in research about how specific interventions impact employee experience, peer and supervisor perceptions, and companies' bottom lines. We're thrilled to have the opportunity today to share the lessons from that work. We've already taken steps at USAID to draw on its lessons. In the past year, we have provided the agency more tools to support our work on MHH. We launched a new standard definition that reflects the multi-sectoral nature of this issue. We've set new requirements in place to help us gather information about what the agency is doing on MHH. And later this year, we hope to release new technical guidance on MHH that we hope you all find useful. We recognize there's still so much to do. Hundreds of millions of people are unable to participate safely, equally, and confidently in educational, social, and economic activities simply because they menstruate. We need to work together to build a committed and diverse community of practice to help address those gaps. So it's truly wonderful to see people from all over the world who work on sexual and reproductive health, gender, WASH, education, youth engagement. There is space for a truly multi-sectoral community to come together to help us better reach men and women, boys and girls with context-specific information, support for social behavioral change, products, services that they need to create supportive environments for menstruation and to enable menstruators to fully engage in their lives. So we truly hope that the evidence presented today will get everyone excited to take on this huge challenge together. Truly thank you all for coming, and thank you for listening and engaging with the information, and hopefully we can all think of what our next steps can be together to take this work forward. Thank you so much.
Thank you so much, Jamila. Really grateful for your time and your leadership and your agency-wide and government-wide support of this issue. That kind of leadership is really invaluable. Without further ado, I'm going to turn it over to our partner group to start going over what this activity did, as well as the results that we've learned. So, Katie, if you could pull up the slide whenever you have the chance. And I will turn over to Michal Avni, who's going to walk you through what this amazing piece of work looked like.
Thank you, Lisa, and welcome everyone. I'll be providing a brief overview of the menstrual hygiene management in the workplace action research. Next slide, please. Our main aim was to determine if providing adequate menstrual hygiene management, or MHM, in the workplace will contribute to improved business and social outcomes, including women's economic empowerment. To answer this, we looked at 3 research questions. Research question 1 sought to understand the social and financial costs and benefits of adequate MHM in workplace settings. The second question intended to tease out the various internal factors, such as the demographic makeup of the workforce, and external factors, such as the broader national policy environment, related to implementing MHM interventions in the workplace. We're trying to understand what most influences and contributes to adequate MHM in a variety of settings. Question 3 focused on measurement. How can we best measure adequate MHM in the workplace and advance the body of evidence? Next slide, please. So in the previous slide, I used the term adequate MHM, and you might be wondering what that is. Adequate MHM is defined by the World Health Organization and UNICEF as occurring when women and girls have awareness, information, and self-confidence regarding menstrual hygiene, when they have access to safe, hygienic, and absorbent materials and supplies, when they have access to safe and clean facilities that are equipped with water and soap and that offer proper means to dispose of used materials, all of which are embedded in a supportive environment that allows women and girls to manage their periods without fear of stigma. Next slide, please. I would like to highlight that the nomenclature around menstrual health has been evolving globally, and it has shifted within USAID since the launch of this project. The preferred terminology is menstrual health and hygiene, or MHH. MHH encompasses MHM, but it goes farther than MHM in a number of important ways. MHH is more inclusive in its definition of people who menstruate, addressing women, girls, transgender, and gender non-binary individuals. MHH also addresses hygiene, but it extends further to include health concerns, particularly sexual and reproductive health. And it addresses broader social norms through social and behavior change efforts. And then finally, MHH also considers a broader system-level approach to menstruation. Next slide, please. We developed this conceptual framework to inform the full MHM action research. Our aim was to understand how MHM, which is on the far left of the diagram, impacts on women and employers in the short term, And what are the implications for longer term outcomes like women's economic empowerment and future revenue streams, which you see on the far right of the diagram. As indicated in the blue panel, we imagined menstrual health to impact working women in various ways. For example, an employee who has difficulty managing her period at work is more likely to be uncomfortable and stressed, and which could negatively affect her economic empowerment and her agency. At the same time, as shown in the red panel on the bottom, we expected MHM to directly influence businesses. For example, a workplace known for poor treatment of menstruating employees might have difficulty recruiting the best workers or experience high turnover, both of which would affect its bottom line. And of course, there would be some shared impacts, those that would affect both working women and the businesses that employ them. So the high turnover that I just described could reduce productivity for the business, but for women employees, it could mean limited promotion opportunities and lower earnings. Next slide, please. Our project focused on working women in manufacturing settings in Nepal and Kenya. In Nepal, both workplaces were family-owned businesses that produced high-end, handmade luxury carpets for export. Workplace A, which had a 9-month implementation period, was male-dominated, employing about 50 women and 80 men, while Workplace B, with a 5-month implementation period, had majority women workers, employing 69 women and 28 men. In Kenya, we carried out 9-month interventions in both workplace settings. Workplace A was a family-owned leading manufacturer of textiles, covering all aspects of fabric production. It employed nearly 700 staff, 10% of whom were women. And Workplace B was a garment manufacturer that produced finished products for export. It employed nearly 500 staff, 80% of whom were women. I'm going to pause here to show a short video that will give you a better sense of the settings where we worked and basic elements of the intervention. Great, thank you. Now you have a sense of where we worked, what things look like. I have the next slide. Thank you. Okay, great. From the start, we intended to implement a light touch intervention, one that would be least disruptive to the workflow and production goals of our private sector business partners. We also faced a range of COVID-related restrictions that further forced us to keep the in-person engagements with employees very brief, to about between 30 and 60 minutes a month. In all four workplaces, the intervention included three main components. We offered free menstrual products and some infrastructure upgrades. We reviewed existing workplace policies and developed recommendations to make them more supportive of menstruating employees. And we provided brief education sessions that were reinforced by behavior change communication, or BCC, to support menstrual management and reduce stigma. Next slide. So first, regarding products, in Nepal, the intervention provided free reusable and disposable pads. In Kenya, we distributed both types of pads plus the menstrual cup. And as for infrastructure, we carried out an assessment of the toilet facilities and provided basic recommendations. Minor upgrades such as locks and hooks on doors were done by the project, and more significant upgrades were carried out by the factories themselves. We can see some of the changes that were made in the toilets on the far right photo. Next slide, please. All right. In all four settings, the project developed customized BCC, behavior change communication materials, to reinforce brief in-person education and sensitization sessions on MHH. In Nepal, the team developed BCC materials that relied heavily on graphics and videos with limited text to address the low levels of literacy among employees at the factories. The images depicted in the products were contextually relevant to the carpet making factory settings and ethnic composition of the staff. Next slide. In Kenya, the team created BCC tools for different cadres of staff at the workplaces, including workers and other key influencers such as managers and leadership, the nurse and first aid provider, guards, and cleaners. Here too, products were designed to be accessible by using simple language in English and Swahili, corresponding to staff's level of literacy. The products also depicted fictional workers in similar uniforms to those worn at the workplaces. The BCC materials were disseminated through print and digital modalities. Digital infographics were shared via SMS and WhatsApp to women employees. And at this point, I would like to turn it back to Lisa.
Great, thanks so much. And just a reminder, if you have questions as we go, do feel free to drop them in the Q&A box. Before we move on to sharing the results with you, I'm going to turn briefly to Adriana Hayes, who is, as I mentioned before, the Acting Mission Director of USAID Nepal. And she's going to share a few reflections from the standpoint of our Nepal mission. It's getting late there, so we appreciate you allowing us to interrupt the presentations to hear from Adriana so that she can go on with her evening. Adriana, thanks so much for joining, and over to you.
Well, thank you so much for having me. I'd like to say, first of all, namaste to everyone, and good evening from Nepal. I particularly like to extend my thanks and greetings to our colleagues from the Bureau for Global Health and Resilience and Food Security, and especially the participants and the employers who hosted the Nepal research activity, and our implementing partner colleagues. And of course, welcome to all the participants who are joining us to learn about this really interesting activity. It really is my pleasure to represent USAID Nepal at this important event. We're so glad that we got to be one of the pilot missions and learn through this wonderful activity. So, as we've discussed, approximately 500 million people worldwide face barriers to managing their menstruation in a safe and healthy and dignified manner. And especially in low and middle income countries such as Nepal, these barriers really can be acute and include insufficient knowledge, a lack of products, a lack of latrines, a lack of water for washing, and also social support. So we were particularly excited that this activity, which is really one of the first of its kind in the world, focused on the menstrual needs of women in the workplace and findings that we can help contribute to the global evidence on menstrual hygiene management in the workplace. So we will learn during this event, as we already are, that the activity's research findings confirm what we've suspected, but we now have increasing evidence for, which is that when women's menstrual health and hygiene needs are met at work, that there's benefits for both women employees and their employers, as well as for male employees. I'd like to talk a little bit about the USAID and WASHPaLS partnership with the private sector, focusing on the inclusion of women in the workplace. This is an example of how USAID and the private sector are contributing to the good of everyone through a partnership. And this support is really good for business, and it's good for women, and it's good for society overall. Focusing a little bit on Nepal for a minute specifically, it's really important for us to also recognize the great strides that the government here has made in addressing menstrual hygiene management, particularly in schools and communities. And the National Planning Commission here has formally recognized menstrual health and hygiene in the workplace as the third pillar beyond schools and communities, along with menstrual hygiene at home and school. But without the private sector businesses' cooperation and buy-in, we would not have been able to produce and take actions on these research findings. The partnership created by this activity created the expertise and skills and resources that are critical to sustain progress and results in Nepal's complex and competitive business environment. I particularly want to really thank the two businesses who joined us in this partnership for their willingness and their forward-looking vision. So thank you to Shangri-La Carpet Factory and Milha Custom Rugs for joining us in this activity. You have helped forge a new path forward for Nepal and established a model for the rest of the world to learn from. And I want to thank the women and the men and the employees of these factories for their participation and for their enthusiasm and interest in continued learning. As we look at continuing to grow our private sector collaborations, USAID is going to continue to emphasize partnerships that fulfill our joint responsibility to improve society and make sure economic growth is inclusive of vulnerable, poor, and marginalized populations. I really want to thank once again the whole group of partners who are advocating for and really actively participating in and pursuing menstrual health and hygiene goals. And I'd like to call on everyone who's joining us here and who you work with to celebrate these efforts and make a public commitment to support the improvement of menstrual hygiene management, helping to remove another obstacle to the advancement of women and to the promotion of gender equality. So thank you very much for allowing me to join you all tonight and share these remarks.
Thank you so much, Adriana. Really grateful for your time and for your support of this activity. While Katie pulls up the slides, I'm going to turn now to Aditi Krishna, who's going to present the results from the work that Michal just went over. So over to you, Aditi, and thank you.
Thanks so much, Lisa. And thank you all for joining us. Before I dive in, I wanted to note that I'm speaking on behalf of a much larger team, some of whom are on this call and will chime in during the Q&A. But just want to acknowledge the incredible work that they all have done and wish we could all get a chance to present here today. I'm going to be speaking about findings from our workplace interventions, presenting only selected results, learnings, recommendations, and future research priorities. The learning briefs and the full final report, which will be linked in the chat box, contain more details, and I encourage you all to reference those for further details. The first few slides here will focus on comparisons from our baseline and endline assessments, during which we conducted surveys with women and men employees, focus group discussions, just previous slide for a second. Focus group discussions also with employees, and key informant interviews with leadership and management. So as you saw, a quick glimpse, next slide please. I'll share one result that pertains to an overall increase in awareness, information, and self-confidence relating to menstrual health and hygiene. So this slide shows data on confidence in managing menstruation as reported through the women's questionnaire at baseline and endline. There's a single item asked of the women employees. At endline, there was greater confidence in women employees' ability to manage their periods, with a larger difference between baseline and endline in Kenya compared to Nepal. As you all can see, and perhaps quickly calculate, there was a 57 percentage point difference in Kenya, and a 10 percentage point difference in Nepal between baseline and endline, that is. I'd like to note that our team did not conduct statistical tests to compare differences between baseline and endline between the two countries. However, we did triangulate the data using qualitative information from the focus group discussions. In Nepal, quite a number of women, 62% specifically, reported feeling quite confident in managing their periods at baseline. They did so through maladaptive coping mechanisms such as overwearing products. Our intervention sought to increase knowledge about menstrual materials, amongst other things that Michal mentioned and that will be mentioned later through the presentation, leading to changes in these maladaptive practices and greater confidence in managing menstruation. That's the 10 percentage point increase in reported confidence in managing menstruation. Next slide, please. So access to products also improved, unsurprisingly, as product provision was a key aspect of our interventions. So now I'm going to present data from 3 items from the women's questionnaire, with a panel showing up one at a time. Just to walk you through these graphs, the blue bars present data from Kenya, with the red bars presenting data from Nepal. The lighter bars represent baseline data, with the darker bars presenting endline data. So in panel 1 on the left, a greater proportion of women employees reported that they could get more menstrual products when they needed at endline relative to baseline in both countries. Next panel, please. So in the center, you can see, again, in both countries, more women said that their products were more comfortable at endline. Next panel, please. And then in the last panel on the right, at endline, there were more women who never worried about leakage, especially in Kenya. And this is leakage of menstrual blood to one's outer garments. In Nepal, this difference wasn't very large. It's only 3 percentage points, as you can see, likely due to a large proportion of Nepali participants who use disposable pads while working at baseline. In contrast, in Kenya, fewer women had access to more absorbent products like pads, and sometimes used cut pieces of cloth, which were more prone to leakage. Next slide, please. Now I'm going to present a few outcomes related to workplace outcomes. Job satisfaction improved in both countries from baseline to endline, approximately 39 percentage points in Kenya and 27 percentage points in Nepal. We also gathered qualitative evidence suggesting that women employees were happier to work in workplaces that were supportive of menstruation. Next slide, please. And fewer women reported missing part of a day due to menstruation-related reasons at endline compared to baseline. As you can see, this difference is particularly notable in Kenya, but not so in Nepal. This is because in the 2 workplaces that we partnered with in Nepal, the workers lived on site. So when they missed part of a day due to menstruation, they could make up that time at a different time in the week, whether earlier or later, if they anticipated missing that time. And they didn't report absenteeism as a result. Next slide, please. Now I'm going to read some quotes that give us information relating to productivity and presenteeism, both of which improved over the course of the intervention. I'll just stop to define presenteeism for a second because it's not a term that everyone is comfortable with. And at the beginning of this work, I thought it was the inverse of absenteeism. But really, presenteeism refers to a diminished concentration or ability to perform one's tasks properly and adequately at work. So the first quote is from a woman employee in Nepal. It reads as, "Less work means less money. So despite pain, we want to be present at work." Now, referring to after the intervention, we are confident enough to share our issues to the manager, enjoy the short rest break, and go back to work. So this first quote suggests that after the intervention, women are no longer sacrificing earnings by taking unpaid leave when menstruating. The second quote in dark blue is from a supervisor in Kenya. "Supervisors feel good because they're answerable for production and targets, and when women are comfortable, the targets are met and supervisors feel happy and proud." The second one suggests that greater comfort is associated with greater productivity. Next slide, please. Now I'll transition from presenting baseline and endline comparisons to speaking about key learnings from the overall activity and recommendations that we've drawn from these learnings. Next slide, please. Workplace MHH does not fit squarely into any one sector. Both Jamila during her introductory statements and Mihal during the project overview shared that MHH encompasses not only menstrual products or access to toilets, but it also involves access to healthcare and body literacy, social norms, and gender equality. Indeed, the experience of menstruation diminishes women's chances of being treated as equals in the workplace. When women need to take menstruation-related leave or ask for more frequent bathroom breaks when they're menstruating, their performance may be viewed as inferior to that of men employees, and they're less likely to be valued or promoted. It even hampers relationships with supervisors when they ask for these frequent breaks. And it is even harder for younger, less literate women working in less stable jobs to deal with their periods safely, hygienically, and with dignity. This shows that MHH is made more challenging by intersecting inequalities. Next slide, please. The complexity of MHH is evident. Accordingly, it needs to be addressed by a multi-sectoral approach that brings to the table experts from different disciplines such as WASH, health, gender, and far beyond that. Next slide, please. Workplace MHH policies, if they do exist, do not do so in a vacuum. They're critically informed by national policies relating to MHH and more broadly to workplace health and safety. The policy reviews that we conducted as part of our interventions highlighted the complementarity of national level policy mandates and the critical need for multi-level policy efforts to improve women employees' abilities to perform their best at work. We recommend alignment between workplace and national policies. National policies would support and enhance existing workplace policies, and they would promote workplace policies where they do not exist. Next slide, please. The intervention's primary focus, as we've noted, was on women employees who menstruate. However, the team recognized the importance of engaging men because men were colleagues and in some cases family members who worked alongside women employees. They were also in positions of power as supervisors and as many of the supervisors and managers in all four workplaces were men. In some workplaces, the owners of the company were also men. In all workplaces, women felt wary of engaging men. In Kenya, the culture of silence relating to menstruation had to be broken in order for women to feel comfortable in engaging with men. In Nepal, women preferred to have separate education sessions from men. The research team acknowledged these concerns and requests, tailoring activities to ensure women's comfort and safety before pursuing male engagement activities. Our recommendation to future efforts is to recognize how and when men can be supportive, while understanding that there may be times when male engagement can be perceived as unwanted or harmful. Future efforts should work with menstruating employees to understand the conditions under which constructive male engagement is possible. Next slide, please. So there's an assumption that only adolescents lack MHH knowledge and working persons know how to manage their periods. This assumption fails to recognize that many in the workforce may not yet be adults or have formal education. It also assumes that they've received menstrual education, and if so, the education is accurate. As a result of these assumptions, most BCC materials are designed for younger audiences and are not appealing or relevant for working adults. So our recommendation is to tailor BCC materials for the needs of adult workers. The images, the content, the delivery all need to be adapted to adult audiences. And formative research is critically needed to inform their design and content. Next slide, please. So sustainability is a key issue for all development initiatives. Many of you who are on this call, that's top of mind when you design and initiate activities. How can programs continue to have reach beyond their project cycle? Our action research found that engaging with experts and stakeholders in country and regionally was a key aspect of ensuring the continuity of our efforts. Additionally, using locally produced menstrual products and services was important because these products were designed with local preferences in mind. Furthermore, many of these products were affordable and their provision and distribution could continue even after the end of our interventions. Accordingly, we recommend engaging with local stakeholders, including experts, policymakers, as well as designers and producers of menstrual materials in pursuit of sustainability. Next slide, please. So building on these learnings and recommendations, our team wanted to share some priorities for future research. And indeed, we encourage you all to drop your thoughts in either the Q&A box and the participant chat. So here are 5 that we've highlighted. The first towards the left is, what are the best practices to improving MHH in different work settings? We worked in 4 workplaces, which were all in the formal sector, 2 carpet factories, a garment factory, and a cloth factory in 2 countries. What are the challenges experienced by menstruating employees more broadly in different sectors? And what are the best approaches for addressing them? Second, in the center, what are the kinds of policies that workers need to meet their menstrual needs? Is it paid leave when they're menstruating so that they don't have to sacrifice earnings when they need to take time off? Is it changing the nature of their work so that it means less physical exertion or more breaks during the day when they're menstruating? Or is it a break room with pain medication and a hot water bottle and a bed to rest on? Or is it free provision of menstrual products in the workplace? The third recommendation on the right, the third priority, how can supervision practices and workplace incentives support MHH in the workplace? What can supervisors do to best support menstruating employees? And how can programs sensitize supervisors to do so? And how can MHH programs be promoted to employers and workplaces? On the bottom left, what is the relative benefit of the different components of the workplace interventions? Which is more important? Is it providing products? Is it improving toilet infrastructure? Is it creating disposal options? Or is it advocating for policy and workplace change? Or distributing information about menstrual health? Or is it really a combination of some of these or all of these? Our research wasn't able to discern the relative contributions of various combinations or components of these in isolation, and future work could explore this. And the last priority that I wanted to share is our interventions focused on workplace interventions with the mandate ending at the workplace. But what would be the added effect of a broader MHH intervention that looks at community level influencers and determinants and has a complementary community-based component as well? Could it be more effective because it is broader and recognizes these multiple spheres of influence? These are questions that we hope will get answered in future work. And with that, I'll close this part of the session and turn it back over to Lisa.
Thank you, Aditi. So we have about 10 minutes for Q&A. So I'm going to ask Michal on video as well. Thanks to those of you who have been dropping questions in the Q&A box. As you will hopefully have seen, some people are getting responses in writing, and we're going to get started with discussing some of the questions you've put in there as well. So the first question is, thank you for sharing research results. I'm interested in what the long-term outcomes we can expect. Do you have any case studies from participants of the research, such as sharing from employees from those workplaces? So I think the interesting point of discussion here is really that part of the question that's about the long-term impacts. So Aditi, Michal, do you want to get started? And also, just for everyone's awareness, we also have with us Maneshka and Whitney, who've just come on. Maneshka was the lead of this activity in Nepal, and Whitney was the lead of the activity in Kenya, and so they're here to provide any additional information specific to those two countries. Aditi, do you want to start on the long-term impacts?
Sure, absolutely, yeah. I will note a giant caveat here that our interventions only lasted up to 9 months, and the activity itself ran, the implementation of the interventions, including baseline and end-line monitoring, was about a year. So that was about the time frame that we had for monitoring short and medium term impacts. We hope that our activities will set in place and catalyze longer term impacts. As you saw in our conceptual model, we hypothesized that the activities that took place as part of the interventions would lead to women's economic empowerment, and would lead to changes in the business bottom line or future revenue stream. However, future research will be needed to fully gauge our progress towards those longer term impacts. I don't know if anybody else wants to chime in there.
I would echo what you said, Aditi. We have a lens now into what this looks like over a relatively short period of time. But the question from the participant is a really good one. It is so important, I think, to be able to invest in this kind of work on the longer term basis so that we have more information and we can say what are the longer term outcomes. We just don't know that yet. We can hypothesize.
Thank you. Another question came in about the policies that were in place in the 4 workplaces where this intervention took place. Did they already have policies that spoke to MHH, and can you give a little bit more information about what you did to support that? Michal, do you want to start with that, or?
I think this is a perfect question for Whitney and Maneshka to take on, to speak specifically about the countries.
Perfect. Maneshka, do you want to start with Nepal?
Sure. In the case of Nepal, thank you, Lisa. The 2 companies did not have policies related to MHH. So what the team did was to provide technical assistance on what could be included in HR policies. But we took policy work a little bit farther as well. We worked with the MHM Partners Alliance of Nepal, led by Gunaraj Shrestha, and we engaged with the National Planning Commission, who then recognized formally MHM in the workplace as the formal 3rd pillar of MHM in Nepal. And we have been engaging very closely with policymakers at the national level as a result. So we not only worked at the company level, but we also took it to the national level thanks to our engagement with the MHRM partners alike.
I'll just add a little bit from Kenya. Thank you, Minashka, for adding that for Nepal. We conducted policy analyses in both of our work sites in Kenya, and while there were no MHH-specific policies, we recognized ways in which all of the existing policies could be bolstered, could be enhanced, such as onboarding procedures, ways that policies that might be in existence could be enhanced and also implemented. So we worked closely with the leadership to guide and to, if they were interested in carrying out some of these recommendations, also looking at representation and voice, and other ways that that MHH related needs can be infused. In Kenya, we also leveraged the recently released MHM policy that the government released last May on MH Day, 2 years, actually almost 2 years ago now. And so the policy framework at large nationally was really helpful to guide us. Our advisory committee also was a useful resource as we continued to guide and advise the partner companies on issues of policies.
Thank you. Whitney, I'm going to ask you to stay with us for a minute, and I'm going to, in the interest of time, I'm going to ask you and Minashka 2 questions in one. And Whitney, since you just had the floor, you can get started. So the first is about the work that was done collaborating with the leadership, the supervisors in the 2 workplaces. What were their responses among supervisors and management? And then the second question is kind of more broadly about male engagement. What types of informational materials were directed at men, and then additionally specialized staff such as cleaners and administrators, and to kind of bring everybody on the same page about the information that was also being provided to the women who also had a lot of knowledge gaps. So 2 questions in one. Whitney, take it away, and then Minashka, when she's done, feel free to jump in on the Nepal context.
Great, thanks, Lisa, and great questions from the audience. These do fit well together because a lot of our supervisors were men. A lot of the leadership were also men. We had one woman in leadership at one of our factories. In terms of engaging the leadership and the managers, initially there was some hesitancy. Menstruation is not a commonly discussed topic, but over time, as we were able to break the culture of silence around menstruation, more and more of these conversations were coming up, and the comfort there to speak about menstruation really grew. In terms of the male engagement piece in our work in Kenya, we found, particularly at one site, one workplace, that the women were initially very hesitant to engage their male colleagues. They didn't want men in their workplace to know that they were talking about menstruation. They didn't want the men to be engaged. So we worked really closely with the women to work in ways that they felt comfortable. Once the culture of silence was broken, and they felt more comfortable to discuss menstruation and recognize that their needs were valuable and important, then they began to actually understand, well, actually, maybe including men in this conversation would be helpful, and let's actually ourselves design that. So we engaged in appreciative inquiry or a strengths-based process to where the select group of women in that particular factory were able to design a male engagement intervention that includes supervisors, that included male allies in different departments. And they developed a menstrual health committee that would carry on long after this intervention. In fact, they're meeting regularly now and engaging their colleagues in conversations around menstruation on a regular basis, which is really exciting, all led by this group of women that chose to reach out to specific supervisors on their team and men in their midst. So that's just one example of a participatory approach to male engagement that really seemed to work at this workplace. And also the fact that it's carrying on beyond the intervention is really exciting. Over to you, Minashka.
Thank you, Whitney. I'm going to start with appreciative inquiry as well. So we tailored an appreciative inquiry approach to working with supervisors and managers in the case of Nepal. It was important for us to keep management abreast of what we were doing. So there were conversations, informal as well as appreciative inquiry conversations that were carried out at least once every 2 to 3 weeks with management and owners. And so we established a culture of collaboration with the leadership. Also to note is that all of the management and leadership and supervisors at both factories are male. And it became very clear from the very beginning of our work that engaging males was going to be extremely important. Like in Kenya, there is a culture of silence in Nepal, throughout Nepal, especially among populations that are slightly less literate. And so the women wanted the men engaged. However, they wanted separate sessions, and that was understandable. It was interesting towards the end of the project, though, they said if this program had gone on for longer, it would have been great to have combined conversations with men and women. Our approach to male engagement was that men and women received the same education and BCC materials. And we also portrayed men in positive and supportive ways in the materials that we developed. So we wanted to make them part of the conversation as per the request of the women.
Thank you so much, Mineshka and Whitney. We still have a number of questions in the Q&A box, and we will get to those as quickly as we can. Some of them I can just flag will be better answered when we are able to share the final set of learning materials and activity report on globalwaters.org. Many of the materials are already there and those have been posted in the chat. And we will have coming soon a learning brief on male engagement specifically. So that'll provide some case studies and a little bit more information about what you've just heard, as well as recommendations that we can all be thinking about. And that links to some of the other comments that I'm seeing come in about how sexual and reproductive health ties into all of this. I know you've heard briefly, but just to reemphasize, one of the things that we found kind of the most interesting and exciting about this work was that demand for sexual and reproductive health information and contextualizing menstrual health and hygiene information in SRH. So there's a lot more that we can all do together to test new approaches and really learn from this demand for a multisectoral approach. So with that, we're going to kind of keep going with the agenda. Just a reminder that we will have about 20 minutes at the end for those who can and wish to stay on discussion. And in the meantime, we will continue to respond to as many questions as we can in the Q&A box. So please continue dropping those in. So with that, I'm going to now turn to Beverly Mademba from our Kenya mission, who is going to share some reflections from Kenya and how this links up to their approach. Over to you, Beverly, and thank you.
Thank you, Lisa. Would you please confirm that you can hear me well?
Yes, perfectly. Thank you.
Great. So, hello, everybody. Thank you so much for joining this webinar. And I appreciate this opportunity to make remarks from Kenya. My name is Beverly Mademba, as you've heard, and I currently serve as a WASH specialist with the USAID Kenya and East Africa team. And as some of you here might know, I'm also an avid MHH advocate and practitioner. It is wonderful, actually, to see in the participants list so many MHH advocates and practitioners with whom I've had the honor of collaborating with along the years. This is a first of its kind research in Kenya, looking at MHH in the workplace. We at USAID, Kenya and East Africa, therefore, receive the findings from this MHH in the workplace study with enthusiasm for several reasons, actually. First is that the subject matter, that being holistic MHH, as well as addressing the needs of girls and women, are a priority in our country development strategy, CDCS, which I invite all of you to look on our website because it's a public document. As such, the clear evidence generated by this study, which is that investing in MHH is both good for people, as we've seen clearly impacting women's economic empowerment, improving their self-agency, to mention but a few, and it's also good for business, including in reducing missed workdays and improving job satisfaction. We find that this clear evidence will go a long way in informing not only our activities design, further research, as well as our continued engagement with the government of Kenya on development and implementation of holistic MHH relevant policy, technical guidelines, strengthening institutions, to name but a few. This is not only in our WASH portfolio, but is important for impactful investment in trade, all towards sustainable economic growth and inclusive development. As many of you here might know, Kenya has a strong foundation of work on strengthening the institutional and policy framework on menstrual health, a testament to the government's leadership in this area. For instance, Kenya was among the first countries globally to repeal the value-added tax on menstrual products in 2004. As of 2011, the government provides disposable menstrual pads nationwide to girls in schools through the sanitary towels program. We, of course, also have the MHM policy and strategy that was passed in 2020, as well as adopting the first ever standards in Kenya for reusable menstrual products in 2020. All of this is not mentioning the myriad of technical guidelines, the multi-stakeholder structures that have been established to support the implementation of the MHH agenda, and all other interventions intending to increase sustainable access to menstrual products. While recognizing all these advancements, we do recognize also that there is still large ground to cover until all menstruators can manage their menstruation and all related reproductive health needs with dignity across their entire life cycle. The challenges are further exacerbated for specific populations, including, as we've seen, workplaces, for menstruators living in the streets, for menstruators with disabilities, and so many other subpopulations. We are keen, therefore, to continue exploring solutions that ensure that no single menstruator is left behind. This requires all of us to look at innovations such as this research, as well as to engage stakeholders who historically did not engage in the MHH discourse, like the private sector, textile factories, and others. This is the only way to design evidence-based interventions contextualizing to the specific unique needs. We look forward, therefore, to continue customizing this intervention, adopting the BCC material that has been developed through this study, and to applying the findings from this to other workplaces. We recognize that the textile industry, where the study was done, is but an entry point to other workplaces. We also look forward to applying these findings to have an impact at the systemic levels. I just wanted to make mention to the Kenyan colleagues in this webinar. Please keep an eye out for the learning brief, Kenyan specific learning brief that is to come, even as we continue with the dissemination. In conclusion, we at USAID Kenya are excited to continue partnering to achieve transformational change in Kenya by improving work environments for all menstruating people. In addition to our support of this menstruation at work study, we will work over the coming years to strengthen markets for sanitation and hygiene products, including in upcoming activities in Western Kenya, and to continue investing in research in order to better inform governments, donors, and practitioners on cutting-edge solutions on these issues, all in alignment with and supporting the government's MHH agenda. So I say thank you very much to WASHPaLS team for leading this work, and I hand back to you, Lisa. Thank you.
Thank you, Beverly, and thank you for your leadership. We all have a lot to learn from you and your great work. We're going to keep going now. Excuse me. There's a number of questions that have come up about cost-benefit analysis and willingness to pay. So you all are in the right place. As the slides come up, I'm going to invite Jake to take over, and he's going to share an overview of the cost-benefit analysis that was conducted with this activity. And there will also be a learning brief on this coming soon, so keep an eye out for that. We're hoping to have it posted by the end of the month. And in the meantime, here's a preview. Thanks, Jake.
Hi, everyone. Thanks so much. And so today I'll be speaking about what were the actual results of the cost-benefit analysis. Next slide, please. So for those of you who are unfamiliar, cost-benefit analysis is a data-driven approach to decision-making. It describes a method for comparing the projected costs and benefits associated with a project or policy decision to determine whether it makes sense from an economic perspective. The final outcome is determined through a benefit to cost ratio. So any value over 1 implies that the benefits outweigh the costs. You'll see some graphs coming up that show those ratios. So in our final analysis, we looked at the following project costs: the cost of menstrual materials, improvements to infrastructure, which could include anything from installing a hand washing station to building a new latrine, and the labor costs required for employees to participate in a core program team to implement sessions. The benefits included reduced absences, which were valued at women's average wage at work, reduced healthcare expenditures for menstruation-related care, such as infections. So what were women paying every month going to the doctor? The third one is women's economic benefits, and that describes the average value that women were willing to pay for the intervention. And we arrived at this figure by doing a willingness to pay survey across all 4 work sites, as well as a 5th in Tanzania. And in this survey, participants were given the choice between 2 hypothetical jobs. So one in a workplace with an improved MHM environment, which is similar to our intervention, and another nearly identical work site, which didn't have an intervention, but it paid a marginally higher salary. By varying this salary, we're able to determine an average willingness to pay for the intervention. And then the last benefit was time savings. And that was specific to one workplace in Nepal, which built a new latrine. And as a result, women no longer had to walk home to change their menstrual materials. Next slide, please. So we are very pleased to share that the average benefit to cost ratio for the project was positive. On average, for a 10-month intervention, every $1 invested returned $1.40 in benefits. That's a BCR of 1.4. Now, because the recurring costs of the intervention are low compared to the fixed upfront cost, for example, menstrual cups are very expensive, but they last several years, we projected the costs and benefits out 2 years. And over 2 years, with that projected BCR, the benefit to cost ratio increases to 219. The largest percentage of benefits, on average, just over 60%, comes from women's economic benefits. And that's the valuation of improved MHM from the willingness to pay survey. Just under 1/3 were in reduced healthcare expenditures, and these were particularly large in Nepal. A further 8% came from reduced absences at work, and the final 1% was derived from time savings. Next slide, please. Now, at each site, the site-specific benefit to cost ratios varied. So here you see all 4 workplaces and what the specific returns were. In the 2 Kenya workplaces, they were very close at 1.5 and 1.6. Nepal factory A and B, workplace A and B, were very different. And the main explanation for why is that Nepal workplace A invested roughly $6,000 building a new latrine, whereas Nepal workplace B only finished their infrastructure improvements at the very end of the intervention. So these costs are not included in the benefit cost ratio. And that's what leads to those discrepancies in the BCR. Next slide, please. Now, again, because the costs are heavier upfront, but the benefits accrue continuously, we projected those costs and benefits over 2 years. And at every worksite, the BCRs for 24 months increased, ranging from 1.1 to 3.0, and they break even at all workplaces. We're not including here some of the other various scenarios that we modeled. That includes an optimistic scenario in which the BCRs are a bit higher, and a conservative scenario in which the BCRs are a bit lower. In our forthcoming learning brief, you can learn more about how we arrived at all of these values, what the specific costs were, and how we modeled these different scenarios. Next slide, please. So we face several challenges in collecting data. One of the largest challenges being obtaining complete and accurate data from factories. One reason is that the complications and restrictions of the COVID-19 pandemic, including shifting policies within each country, made collecting data at workplaces time-consuming and expensive. Because workplace operations were shut down in 2020, we sought to compare data on workplace operations between 2019 and 2021 to determine what impact the intervention was having. But this older data was in some cases unavailable. A second challenge was simply the accuracy and availability of workplace data. Many of the variables we sought to collect, such as absences, were incomplete, and in some cases they weren't sex disaggregated, or in others they weren't tracked or tracked thoroughly. And finally, we were unable to collect more sensitive information, such as sales, due to some competition between the factories. We also found it challenging to collect accurate valuation of the intervention through these willingness to pay methods. So we found considerable acquiescence bias, which is also known as yay saying, in which respondents accepted any salary difference used in the survey, despite the differences sometimes approaching a substantial portion of their current wages. And what we think was happening here is that many survey respondents were answering strategically rather than truthfully. So they may have worried, for example, if the responses would be shared with management and used as a loyalty test. And in our learning brief, we elaborate more on how we collected this data and how we were able to analyze it to make sure that we arrived at a value we were confident in. And then finally, as we've spoken about before, given the need for minimizing interruptions at workplaces, we're only able to collect data at 2 time points. Ideally, in a future project, we'd be able to monitor key variables such as absences and healthcare expenditures monthly, and that would provide more accuracy throughout the project. Next slide, please. So our CBA has shown that there's a positive economic benefit both to businesses and to society for improving the environment for MHM. But where do we go from here? So for businesses, it's very clear that it is worthwhile to invest in infrastructure improvements, particularly to latrines. Addressing stigma has a clear effect on workplace culture for both men and women. That's something that we think that respondents valued highly in the willingness to pay survey, which described differences in culture. Businesses can provide clinic days where education and health services are available on site, or they can subsidize or provide for free menstrual materials. There's also, we think, really an opportunity for businesses to be at the forefront of public advocacy and leadership around menstrual health and hygiene. One of the goals in this project was that rather than shifting this entirely to a development space or from an NGO or human rights space, that we can also begin to have businesses carry this work forward. And similarly, because this intervention benefits society as a whole, businesses could pioneer partnership with governments or NGOs. Now, there's also important actions that governments can begin to explore. So lowering taxes on menstrual products is a first and relatively easy step. Subsidized or free access to pads may be a heavier lift, but both Scotland and New Zealand have shown that this is a feasible public policy goal. The intervention also showed a clear demand for reproductive health education in low literacy workplaces, which in combination with the provision of menstrual materials, we think had a strong impact on reducing healthcare expenditures. And governments are, of course, also well posed to enact stigma reduction campaigns, which are, again, important for culture. And finally, just as with business, we suggest that governments look at partnering with businesses and NGOs to promote MHH in the workplace, recognizing that there's shared benefits between the government and businesses themselves. Thank you all for your time. I look forward to your questions. And up next, I'd like to introduce Dr. Bethany Caruso, who will be speaking about MHM and metrics.
Thanks so much, Jake. I'm happy to be here representing Emory University and Athena Infonomics on our work to advance metrics for measuring menstrual health and hygiene related to work. Next slide, please. So, as you know already from this conversation, MHH research, program, policy, agenda setting has all been growing and evolving, but to date has primarily focused on girls, with the experiences of menstruators who are working understudied until now, of course. So there remains a need, though, for indicators to measure and assess MHH among those working outside the home so we can compare experiences and understand trends over time. Next slide. So the primary objectives of this specific work to develop or adapt existing measures to understand experiences, determinants, and outcomes related to menstruation while working outside the home, and also in tandem among those to identify a set of potential indicators related to menstruation and work. Next. So our approach for this work was multifaceted, as is indicated by the figure here. So I'm not going to go into supreme depth, but we'll reserve that for the report, which you all can dive into when it's released. But I do want to point out a few things. We had many steps that were involved in reviewing survey drafts, engaging stakeholders, cognitive interviewing, to make sure that the measures that we identified and piloted and eventually deployed were strong. We also engaged several documents and initiatives that were currently engaging or had already identified indicators for assessing MHH or related issues like WASH to inform the priority indicators that we identified. Next. The work that we undertook took place in Kathmandu Valley, Nepal, and Nairobi, Kenya. And we did this with a random sample of women in order to not only focus just on the same types of employment that our colleagues at IRIS already did, but to get a broad representation of different work types. Next, and you can advance all the way to the next slide. So I'm going to present the findings. We have over 150 measures that we tested, which will be in the report. But for right now, I'm going to be just presenting the 21 potential indicators, and I'm going to present these by our revised conceptual model. Next slide. So first, our model. So you'll first see that we first identified determinants at multiple levels, including the workplace level, individual level, and the biological level, that we thought would then, in turn, next, have an influence on work menstruation experiences, and then which would also in turn have an impact on outcomes, including outcomes that involved individual well-being and individual employment. Next. So we're going to start talking about determinants at the workplace level. Now, it's important to note, and if you advance the slide, that when we ideally look at workplace level determinants, we would, like the JMP does for schools or healthcare facilities, we would actually assess those institutions. However, those are capable of being done because there are mechanisms or structures in place that allow for systematic data collection among schools or among healthcare facilities, either within specific countries or across specific countries. Those systems are not yet established. So one of the novel things that we've done here is to adapt any workplace level measures so that we can assess these at the individual level, enabling such measures to be taken up by population-based surveys like the DHS or MIXT. So diving into the proposed indicators, we're first going to look at the social environment. Our first proposed indicator is the assessment of the proportion of women who agree or strongly agree that women where they work hide the fact that they are menstruating. Now, I want to point out that for each proposed indicator, we have footnotes. So we have very consciously indicated what sources of information or initiatives have informed these identified indicators. So what we have found in Kenya and Nepal, so next, is that we found a much greater proportion of respondents in Kenya agreed or strongly agreed that women in their workplace hide that they are menstruating. So next we'll look at institutional policies. And again, ideally we would be looking at workplaces, but we can't do that. So as a proxy, what we're proposing is to look at the proportion of women who reported being able to take a break or meet their menstrual needs whenever they needed to while working outside the home during their last menstrual period. Now, this may not necessarily be a policy, but again, it's a proxy and may more approximate a norm in those locations. So what we found in the data is that a greater proportion in Kenya reported that they could take a break to meet menstrual needs whenever they needed to compared to those in Nepal. Now we'll look at physical environment related to WASH. We have 5 proposed indicators, and you can advance through those to start. The first 3 relate to spaces that women have access to, menstruators have access to, that are clean, private, and safe during their last menstrual period. The first one, though, is specific to the workplace, while the second is about while working. We acknowledge in this work that not everybody has a workplace, but has different multiple workplaces that they experience throughout the day. The third indicator is like the first two, but adds additional components, including lockability and availability when needed of those spaces. We also propose looking at the proportion of women reporting that there is water and soap available in a private place to manage menstruation, and also the proportion reporting that they have access to sanitation facilities that are single sex in the workplace. So next, we just want to report on the first two. What we found is that a greater proportion of those engaged in Nepal reported having access to spaces that were clean, private, and safe during their last menstrual period, both at the workplace itself and while working. So next, we'll look at resource availability in the workplace, specifically material access. We propose looking at the proportion of women whose workplaces provided menstrual materials to employees, whether for free or at cost. And what we found is that there are a greater proportion in Kenya who reported that their workplaces provided materials free or at cost. So next, what we'll do is we'll look at individual level access to resources, starting with materials. The first proposed indicator is assessing the proportion of women who reported always having enough menstrual materials during their last menstrual period while working outside the home. And what we found is that there were a larger proportion of women in Nepal than Kenya that reported always having enough materials to change as often as they wanted to while working outside the home during their last menstruation. Next, thinking about knowledge, we looked at the proportion of women who reported that they can usually predict when their menstruation will start. There are other knowledge indicators, but we felt that this one was most relevant to adult menstruators in the workplace. We found that a greater proportion in Kenya reported that they could not actually usually predict the start of their menstruation. Sorry, the Kenya data is on the left there. And now moving on to pain management and social support. Two indicators here. We propose assessing the proportion of women who report that they could feel comfortable seeking help for menstrual problems from a healthcare provider, and the proportion of women who report always being able to get pain remedies when needing during their last menstrual period while working. So just looking at data for pain management, we found that a greater proportion in Nepal than Kenya reported always being able to report getting the pain remedies they needed during their last menstrual period. So now, we do have data from the biological level, which is extremely important for understanding the populations we engage and also to design programs. However, we don't actually think that this is the most useful for regular monitoring at scale, so we don't actually propose any indicators at the biological level. So next, we'll talk about work menstruation experiences, starting with practices and needs. So first, we look at menstrual practices while working and propose assessing the proportion of women who changed their menstrual materials during their last menstrual period while working outside the home. And then in terms of pain remediation, looking at the proportion who reported they were able to reduce their menstrual pain when needed during menstruation while working outside the home. So what we found here is that in both locations during their last menstrual period, if you could just advance the slide one, over 90% in both Nepal and Kenya reported that they changed while working outside the home and that they were able to reduce menstrual pain as needed. So next we'll look at bodily integrity. And so we propose assessing the proportion of women who reported that their work responsibilities prevented them from addressing their menstruation-related needs at least some of the time during their last menstrual period. These proportions are approximately equivalent for both locations, though I want to point out also quite high reporting that work responsibilities prevented their menstruation-related needs. Next, we're looking at self-efficacy and propose two indicators. The first being the proportion of women who reported not feeling completely confident working during menstruation, and the second of the proportion of women who reported not feeling completely confident in their ability to manage menstruation when working outside the home. And you will see that the proportions reporting not feeling confident are much greater in Kenya and are actually almost universal. Finally, we'll get into looking at some proposed outcomes. Now, one thing, and if you'll advance the slide, that I just simply want to point out is that most of these outcome indicators would be ideal for actual programs and assessing program change. But we still present them here as they might be useful for global monitoring. Next. So the first ones look at individual well-being, including stress. We looked at the proportion who reported experiencing stress at least some of the time when they needed to access a location to change. And what we found was that a greater proportion in Nepal reported having never experienced stress or tension compared to those in Kenya. Next, we look at safety. And proposed looking at the proportion of women who reported that concerns about safety at least some of the time prevented them from changing their materials when needed. And we also found that those in Nepal, a greater proportion in Nepal, reported challenges with safety. If you could advance to show the numbers. Great. Thank you so much. So now we'll get into final two indicators we're proposing related to work engagement. First being job satisfaction, the proportion of women who are satisfied with their ability to meet their menstrual needs at their current job. And then the second being lost earnings, the proportion of women who reported lost earnings or decreased pay in the past year due to their menstruation. And we found overall that women are satisfied in a greater proportion, reported satisfaction in Nepal than in Kenya, and that lost earnings were low and that the proportions were less in Nepal than in Kenya. So I just want to wrap up. I know we're at the end of the hour with a few critical reflections on this work. Thank you. Keep moving forward one more slide. So we have this identified list of 21 potential indicators reflecting lots of measures tested. It's important to just re-emphasize that most of these indicators were adapted, informed, and aligned with existing or proposed indicators. And this is really important to maintain this alignment across other efforts for assessing MHH, whether in schools or beyond. But these indicators need further vetting, and hopefully some of you can help, both by in-country stakeholders and experts in MHH and measurement. This is just a start of a conversation. And finally, I just want to point out that these data reflect a very specific place in time. It's unclear if we would have had a similar sample 2 years ago, pre-COVID. We had to have people who were working, and not everybody was working right now. We had some delays because of lockdowns in Nepal, and our sample was quite diverse. So with that, thank you very much. I just want to advance the slides and thank all the teams in Nepal and Kenya, as well as those, if you could advance one more, the teams at Emory and at Athena Infonomics. Thank you so much.
Thank you so much, Jake and Bethany. I think your work really demonstrates that there's a lot that needs to be done by the global community to really make this MHH approach something that we can all understand, defend as smart investments, but also measure in a way that provides comparable data globally. Right now, we really don't have that, short of a few metrics used by DHS mix and the Joint Monitoring Program on water supply and sanitation, but those really only capture the WASH components. And hopefully we've convinced everyone today that WASH is necessary, but wholly insufficient to really have an impact. So I'm just gonna move us into a last round of Q&A for those who are able to stay on. And just to thank everyone so much for spending so much time with us. A lot of data that you've seen today. The data behind what Bethany and Jake just presented are data sets unto themselves that we hope people will dive into and use and analyze and pick up on. There's a lot of recommendations for further research priorities. In addition to the learning brief on the cost-benefit analysis that I mentioned earlier, there is a very thorough report on the data that Bethany and her team collected for those who really want to understand all of these really great pieces of information that were gathered in the process of validating this short list of metrics. An amazing data set, probably the most comprehensive available on the experiences of menstruators who work. There will also be a shorter brief available soon that will help everyone think through the 21 indicators that Bethany referenced so that we can then start using them as a global community and continue testing and refining them. The ultimate goal here is a short survey set that national census entities and global monitoring entities can all take up so that we can do a much better job of knowing what's going on globally. And be able to target our research and our interventions accordingly. The last thing I would just say is, I think it's pretty clear that there's opportunities here for all sectors. The private sector can make investments for the well-being of their workforces as well as their bottom lines, as Jake tried to convince us. USAID and other donors have a really huge opportunity to try and take some of this work to scale and to support a lot more research. Good start, not everything we need. National governments, who we are seeing starting to reflect this issue in their policies. Hopefully this will also convince them to follow the lead provided by Kenya and Nepal and kind of add a workplace pillar and look at available investments there. And then for all of us, we just want to make sure that our coalitions and our partners are broad, because the lived experiences of menstruators are broad and need to be addressed in a broad and holistic way. So I think I'm going to ask Aditi, Michal, Maneshka, and Whitney to join us on camera. And we will take a few more questions. And I'm just looking to see what we have not answered yet. For those who have questions, particularly for Bethany and Jake, please do feel free to drop them in the Q&A box at this time. And thank you again for all of your amazing presentations. Sorry. Aishwarya, can you point me toward the first question that we have for this great group? Great. Can you all discuss, and I'm going to ask Michal to please direct the question to the appropriate person on your team. How did this effort consider sustainability? I think there was a lot of work done to address this. Maybe Michal, if you want to give an overview, and then Whitney and Maneshka can provide specific details from the two countries.
Absolutely. Thank you. It's a really good question, and the issue of sustainability was at the front of our minds from the very beginning of this intervention, because we were reaching out and working with private sector companies and really addressing the daily lives and needs of women employees. And so we knew that by offering free products, which was part of the intervention, one day that tap would be shut, and those products, free products, would no longer be available. So we were very upfront from the beginning of the intervention about the fact that this was a time-limited action research. And so there wouldn't be false expectations, but at the same time, we were very proactive about building sustainability efforts with stakeholders from the beginning and throughout, maintaining them throughout the intervention. I think it'd be great for Whitney and Maneshka to provide a few examples of how that was done in country. And some of it was already alluded to in presentations, but good to reiterate. Whitney, go ahead, you first.
Sure, I can go ahead and start. Thanks so much, Michal. Indeed, sustainability was at the forefront of all of this. Our sustainability partners included local, service providers that might be able to offer a fee-for-service model for an intervention to anyone in the private sector post-intervention based on the research, the evidence that was generated from this activity, and the interest that the private sector would have. We have been channeling those interested companies to sustainability partners to work with, whether it's a fee-for-service or a fee-for-product. In terms of our partner companies themselves, we are so pleased and proud that both of our companies in Kenya have been excited. We've generated that interest within both of them and have agreed to carry this model forward. At least in terms of the products side of things, the infrastructure, of course, has been upgraded, and so that will last for years. In terms of policies, those are ongoing in terms of how those are being implemented, and the behavior change and education sessions. We will continue to channel them to our sustainability partners in terms of how they can seek the technical services that they would need. I'll also add here that we worked really closely with the local MHM community in Kenya from at every step of the way. Our advisory committee was invaluable in terms of the ways that they not only guided us and provided advice to us, but are agreeing and are excited about carrying forward the learnings from this activity in their various spheres of influence. So whether that's in the national policy landscape, whether that's in products, whether that's in education, behavior change. So those are key individuals in Nairobi and beyond that will carry forward the learnings from this research. So that in and of itself, I think, will sustain this effort in Kenya.
Thanks, Whitney. So we had similar sustainability efforts in Nepal. One of the first things that we did was to ensure that the products that we sourced were locally sourced from within Nepal. So even if there were lockdown-related travel restrictions and not being able to source products from outside the country, we were able to get the products because they were manufactured in Nepal, both the reusable as well as the disposable pads that we used. We also built relationships between the private sector and the vendors that we went with. This was done throughout the project as well as at the end of the project. We had MHM champions within the companies who will hopefully continue to be MHM champions at their workplaces beyond the life of the project. We also had several sustainability partners, including the MHM Partners Alliance of Nepal, which has over 100 organizations within the alliance, and the Federation of Women Entrepreneurs Association of Nepal, which is over 5,000 member companies. We did a sustainability partner engagement with these folks at the end of the project, at which point they received all of the materials that we used and a lot of the knowledge base as well. And then finally, just like in Kenya, we had an advisory committee that was made up of key individuals across the MHM sector in Nepal.
Great, thank you so much. And we, again, just another pitch to keep an eye on globalwaters.org activity page. There will be some sustainability there soon. Some of the behavior change communication materials that we're really hoping that everybody will be able to learn from what was done and adapt and move forward without having to start fresh. We have a couple minutes left. I'm going to ask sort of everybody who wants to answer a question about COVID. You know, we're seeing employers cutting down on costs. We're seeing people, as Bethany mentioned, losing employment temporarily or permanently. So the question that we received was, how did the two countries make the case for MHH in the workplace during COVID, when all of these other priorities were starting to be rejiggered as a result? So Maneshka, maybe I'll start with you because I think Nepal had a particular challenge due to the duration and strictness of lockdowns, but also a really important opportunity given the residential nature of the factories. And then you can pass to Whitney, but I'd also love to hear reflections from Bethany on this point. And Jake, if you had any as well, I imagine that this very easily have been an issue you needed to address in your CBA work. So, Maneshka, since I see you big on my screen, why don't you start?
Well, thanks, Lisa. There's a two-part response to this question. Even prior to COVID, it was not necessarily easy to convince private sector partners to open their doors to this kind of pilot research. It's a global first time, and so we really appreciate that our private sector partners were willing to go out on a limb for us and really trusted us. So building that relationship from the get-go was very important. Also, during COVID, we found our second company during the height of COVID, and again, there's a commitment from both of the companies towards their staff. They're both residential facilities which provide housing to the staff as well as family members. On some occasions, especially during COVID, they provided food rations and milk for the children, schooling, and so on and so forth. Working with the private sector during COVID was slightly challenging because of lockdowns across the country, which Bethany, you also mentioned during your presentation. We had expected to do an 11 to 12 month intervention at both workplaces, and at the second workplace especially, we only got to work with them for 5 months. So despite this, the results are very promising. Because we went through 2 lockdowns. And also both companies limited our time at the workspaces. We were allowed 30 minutes every month with the women and the men at the factories. And so our approach had to be very targeted and also respect the needs of the workers and the management.
Thanks. Whitney, do you want to reflect on Kenya?
Sure, I'll just add briefly. I would echo everything Maneshka shared, and also just add that I think this is a really important learning for us in terms of working with the private sector, not just COVID specifically, but private sector priorities and how we can ensure that we are really coming to alignment with those priorities overall, and recognizing when targets and private sector deliverables are really at the fore of their mind, and we're less at the fore, and that's completely understandable. And how can we even so work within that space and to continue to carry out work that is important. It does have an economic benefit, as we've seen. So it comes back to, I think, the relationship that is built with private sector leadership and really understanding those priorities. COVID added an added layer. It was an added layer to that, but I think it further reinforced that lesson of the privilege of working with the private sector and how to do that well. I think that when Jake speaks, I'll let him speak to the complications around the CBA, because I think that gets to us in Kenya most heavily in terms of how COVID affected our work. So I'll pass it on to Jake and Bethany.
Thanks, Whitney. I think the big one from a CBA angle, outside of just the methodological complications of having to do surveys or collect data in an environment in which movement is really restricted, is we'd hope that we'd be able to do a specific return on investment analysis of the study, which looked at the costs and benefits very specific to the factory themselves, to determine whether or not there could be a case that is made that it specifically improves factory productivity. And to be able to do that, we would need to compare, and I spoke about this a little bit, data from the past to determine during the course of the intervention and prior to the course of the intervention, what were the different metrics that the factory uses to determine productivity, and did those change? And I think the biggest issue is it was very hard to compare data from a semi-COVID year to a non-COVID year. So there was both the challenges of accessing data from 2019, which was prior to COVID, and then also just being able to collect good data in an environment from COVID. One of the big recommendations that we have in our learning brief and thinking about how to move this work forward is similar to that, which is being able to do this bigger and in a more detailed way, in partnering with a factory that maybe has very detailed metrics for factory productivity and factory operations. And so that's something that we'd really love to see in the future, to get down more into the fine-grained resolution of what are the benefits of this project. And Bethany, I don't know if you'd like to speak to COVID as well.
Yeah, thanks. I think it's actually a really important question to talk about. I mean, I think in terms of our work, even just logistically, simply getting IRB approvals to collect the data, I think it's actually a feat that we got with those and the data that resulted. And our sampling size, for those of you who are really astute at looking at some of the slides, we had less women engaged in Nepal, around 430 compared to 630 in Kenya, simply because those delayed timelines and because of lockdowns. We had a very narrow window to collect data in Nepal. The flip side of this being is it presented itself as an opportunity to learn about how COVID was impacting women related to work. And so we actually added some questions. These data have slides that we kind of tacked at the end, but they are all presented in the report. And so I can just share a few highlights, I think, from that. We had far more women in Kenya than in Nepal reporting that they had to change their job related to COVID. And more women in Kenya than in Nepal reporting challenges related to purchasing. And this could be because of stores being closed. I think 20% indicated that they had a household drop in income as well. And while the challenges were greater among women purchasing in Kenya, 50% of women in Nepal reported that they weren't able to use their preferred material. So they still had something, but they didn't get what they necessarily wanted during this time. And then the last statistic that I'll share is that up to 35% of women in Kenya reported that they had challenges going to the location that they usually use to change materials during COVID, specifically because they were concerned about COVID. They were in shared sanitation spaces. There were other concerns about accessing the place or having longer lines too. So these are certain pieces that came up related to menstruation. I think that it's an opportunity for us to learn and think about, well, how do we then move forward and merge the results that we have from the great work of IRIS related to program, and also the current times we have related to COVID, and thinking about how do our sanitation systems need to change and accommodate, and also how we make materials available. Thank you.
Thank you, Bethany. I'm going to ask you to stick around. I'm going to ask you and Jake the same question, and you can start first since you've just had the floor. And then we will do just sort of one last round of reflections from everyone and close out. So Bethany and Jake, the question is, what's needed to take your specific pieces of work forward? So for Bethany, what's the next step with the metrics to ideally move us into a place where we all have consensus and we're all using and promoting the same indicators that allow us to be more consistently smarter about making evidence-based decisions? And then Jake, for you, what's the next step on developing even stronger business cases and addressing any of the gaps that you found?
Thanks for the opportunity to talk about this. So as a researcher, I strongly believe in peer review. And that's also a huge part of what this effort entails. I mean, we did what we would like to call, I would like to say that this is a final list, but it's not. This is a first pass. This is the start of a conversation. We have 21 indicators and measures that we're putting forward, but it needs other eyes. And so finding others to engage and help with the decision-making process. There are also a slew of measures and potential indicators in the data set and the report that we have. it might be that, some of the things that we thought were maybe not priority, others in the community think that, we should really elevate this to the level of something that we measure and assess regularly. So there's a list of 21 that is far too big. I think that's not necessarily going to be something that governments take up. So kind of winnowing that down and refining that, and engaging people to help with that prioritization, which absolutely requires the work and engagement of in-country stakeholders within Kenya and Nepal, but also beyond. Over to Jake.
Thanks, Bethany. So I think to build on what I was speaking about earlier, I think working at a factory or a workplace, which is much more data centric, would be extremely helpful. We'd love to be able to get more fine-grained resolution on things like absences and productivity. And I think that's probably only likely at a organization that has a widespread data collection system. We would really love to build on the willingness to pay methodology. I think all of us found this a really interesting area of work. It builds on a wealth of experience in willingness to pay surveys, but this is the first time that it has been applied to anything menstruation related. And one of our hopes there is that we can also integrate that into a household survey, by which I mean delivered at an actual household. We think that there's probably complications of doing that survey in a workplace simply because being in the workplace makes respondents think differently about what the answer is. But if it comes as part of a larger survey, imagine if it was integrated into DHS, that might get very different data. And I think it would be really interesting to continue moving that forward within the MHM field. From that, I think it's possible that we would be able to better answer questions around what is the balance between what the public sector and what the private sector should be doing when we think about governments providing subsidies for menstrual products or public campaigns versus company investments. Having more data and being able to replicate this in different work sites in different areas would shine more light on that. I think, as some of you noted in the comments as well, it is something that we would love to expand to the informal sector. That's been something that we have not talked about specifically in this being a workplace intervention, but it's an area that requires more attention, and that's something that we'd love to expand to as well.
Thanks, Jake. Yeah, the challenge, I saw the comments on the informal workplace as well, and it's a really important point, and we did discuss it. For the sake of this first investment, we felt we needed to be a bit more rigorous in how we defined workplaces, but moving forward, I think it's a huge opportunity for the global community to do more work. We have 3 minutes left, so I'm going to do a lightning round. I'm going to ask each of you one final recommendation for the audience, whether you're speaking to government representatives, NGOs, implementing partners of USAID, or other researchers, keeping in mind that we have everybody from sexual and reproductive health advocates to water engineers on the call today. So, Jake, I will start with you. Do you have one final recommendation?
I would love to do a bigger cost-benefit analysis, multi-sided, with different intervention arms, so that we can better delineate what are the specific contributions of, for example, menstrual materials versus infrastructure, something like that.
Great. Thank you. Bethany?
Great. Yeah, I think it's really important to be able to leverage data if we can compare it and understand it. And so we have great tools and great data that's going to be made available. So if people are looking to do more work related to menstruation and work, leverage the tools that already exist. Don't recreate the wheel. A lot of them, all these measures have been vetted and validated. And please take up the work. It's really important.
Thanks, Bethany. Whitney?
I would like to encourage the reproductive health community and SRH community to really tag along with the MHH space. There's a lot of intersection, there's a lot of linkages. We in Kenya in particular, but I think also Nepal, found so much curiosity and even confusion around the link between contraception and menstruation. And so I think that there's also a need for linking to quality service provision in communities as we look at menstruation, as we look at SRH. So that's my plug to the SRH community.
Great. Maneshka.
I think this was a great first step into MHM in the workplace. I think there's a lot more that needs to be done. We've seen a lot of work that has been done in MHH at schools and in communities, but this is the first time on MHH in the workspace, and so there's a lot more to be learned. And so just like Bethany and Whitney said before, I think encouraging others also to join in on MHH in the workspace. It's not an area that a lot of people have focused on before. There is a lot of space to learn as well, and I really look forward to engaging with others.
Thank you. Aditi.
Hey, jotted down a few, but I'll pick one. I'd really like to spotlight the work that we've done, particularly the contribution of our private sector partners as role models and as kind of positive deviants in this space, and share them with the broader business community to champion this work so that, we have already catalyzed efforts towards that, but building on those to really expand the reach of this program through the business community.
Fabulous. And coming full circle to where we started the day, Michal, what's yours?
Oh, oof. All right. I think what I'm just so struck with is the fact that MHH really is at the nexus of all of these sectors' work. It's something that we said earlier in the presentation, and others have pointed to as well. I think there's such a need to leverage resources across sectors. My challenge is for every sector to think about what is their niche, what is their space around MHH, and how to take that up so that instead of it falling through the cracks, it really becomes an area that is addressed holistically in a meaningful way. I think it's time for that.
Fabulous. And I will close with mine to say, I hope that everybody who's spent 2 hours with us today, you are the champions, thank you for being here, can really come together to think about the fact that menstrual health and hygiene is core to gender equality, female empowerment, women's economic empowerment. But we need to remember that not all women menstruate and not all menstruators are women. And that's a huge for everyone to collectively move into.